the previous workshop we had in 2013. Yeah? So what I'm going to do this morning, folks, is to approach this subject and maybe at the end of this talk, present a different way how ethics could be taught to medical students. And in some ways, many of the things that I'm mentioning during this talk is a continuation of what Professor Morgan said earlier. You know, the very powerful role of the power of role modeling and how role modeling can be set up not only in a classroom setting, but maybe in the field where action happens. And you will see pictures of what happened and how we can use those opportunities to teach ethics to our students. In some ways, it's a personal journey and a narrative of personal journey, because throughout my 25 years in University of Science Malaysia, the university has been very kind in allowing me to participate in events where disasters throughout the world. I remember going to Kosovo after the war, Aceh during the earthquake, and Yogyakarta for the earthquake, and all these events, and bring students with me, some students with me, and participate in these events convinced me that the teaching of ethics shouldn't be in the classroom. You learn a lot more about humanity when you're there on the field with the students, rather than having them memorize a whole textbook of humanities. You know? So that is the gist of what I'm going to talk about. The scope of my talk is really to continue what the WHO has been championing, the interprofessional education. And I think although many people speak about the need to have interprofessional education, in reality, we don't do much of that, all right? And while interprofessional education to some of us may mean that professionals like us sit together, Karen being a psychologist, somebody else being a sociologist, anthropologist, sitting with the medics, I'm going to propose to you that the same arrangement should be done by students. Students of anthropology, students of sociology, students of medicine and of engineering, of medical architect, actors should be in the room, discussing problem-based learning about human and so on. Because I think the interprofessional learning should lead to a workforce-ready collaboration. That will come to later. And I think if we really are serious in that kind of interprofessional education, I think we could challenge the classical and traditional methods of teaching ethics which we do now. Right? I think we can easily challenge those because that may not fit into the scheme of interprofessional education. I will go on to say about what are the core elements of ethics needed by physicians. You know, I'm a physician, I'm a pediatrician. What are the core ethical values I need to have? And what are the values that my students need to have to be a good doctor, to be a compassionate doctor? Because all these core elements are those that will lead to attitude formation and a nurturing, I'm sorry about the spelling, nurturing of ethics throughout the years of training. And I'm going to talk a bit about experiential learning. Not theoretical learning, but experiential learning on the field. All right? And those will lead to very powerful attitude formation and nurturing of ethical behavior. All right? I'm going to touch also, two slides on this, continuation of what Professor Morgan was saying earlier this morning, that yesterday there was a publication on altruism and where exactly in the brain altruism center lies. Prior to this, people were talking about empathy, centers of empathy, you know, with the functional MRI. They can actually map exactly where the center of empathy is. And the center of empathy and center of altruism will light up more and more as you expose students to situations that require empathy and altruistic behavior. So all these centers, the parts of the brain that you have, can actually be stimulated in a real-time environment. And hence, our teaching of ethics should do that, rather than just giving them lectures upon lectures and PBL upon PBL. So those will be the scope, and I will end up my talk by giving a proposal on such an interprofessional education. This is in press. It's going to be published in December, impact factor 5 or something like that. We are undergoing a project now in USM where we take this interprofessional collaborative practice competency from Malaysia's medical professional perspective. This is a a study done by Nurhanis Ruslan to really prove again that the future and the way forward is that kind of collaboration. And again, the Bristol Royal Infirmary inquiry, one of the key features mentioned in there was the health professionals should have more opportunities to complement one another in terms of their skills, you know? Because it is well known that doctors, medical doctors, sometimes assume when you have a doctor in the Parent Teachers Association, for example, that doctor is likely to be the president of the Parent Teachers Group, yeah? Because there is some inherent dominance, you know, medical dominance that permeates through the group, you know? And that kind of dominance led to disasters, actually, because they were not willing to be corrected by others. And that was one of the recommendations, because the Bristol Royal Inquiry say that there must be others who complement these doctors, you know. Others may not be people with a CGPA of 4.8 or whatever, but they may be people who have the right values to make that correction, you know. Because without that, that led to the disaster that we know happened in the 1990s. So that's a very, very firm recommendation from the from the prestigious committee that looked into this tragedy, you know. Because clearly it's difficult for individual professionals to address all health concerns. Very, very difficult, you know. I'm conscious throughout my 25 years in USM of trying to put together professionals from nutrition, from diets, from medical architectures into medicine. Because I think this really should be the way forward. And WHO does mention about this role of IPE to produce a collaborative ready workforce. This is a term which is coming in now, a collaborative ready workforce where students can learn, right? Well, just briefly about the current state, we are more familiar with what we do now because we have a very comprehensive ethics curriculum in place. We have books. In some universities, there are ethics intensive course for students, you know, consisting of lectures, PBL, and videos, and films, and movies. Numerous textbook references on ethics, reflective diaries, lectures and tutorials, and so on. We have videos and we show our students on how to behave and how to communicate. In some universities, they name the modules as human behavior, development and aging, hoping that by understanding behavior, development and aging, you become ethical. In USM, we have the community and case studies. These are all largely theoretical. It's convenient for lecturers, for the deans, for the medical faculty to do it because it can withstand the test, you know, that it is easily examinable. You get high marks in these things, you are assumed to have acquired ethical competency, all right? So, but really the question is, does passing the ethics module makes one a better doctor? And clearly, when you will listen to Prof. Rampal, I think I'm going to present to you cases from the MMC, ethical people who had problems with the ethics in the MMC. Many of them do not have problems passing the exam. Many of them have passed the exam, including the ethics modules, all right? And so on, but still people make mistakes because of other reasons, okay? So, coming then to a perspective of a physician, a pediatrician like me, I am forced to ask myself what really is the essential ethical behavior that's needed of me. We will hear more about this mercy because this is now ongoing in USM. Prof. Azwani will talk to you about this particular assessment of this approach. When we force ourselves to see what are really the core values needed of a doctor and a student of medicine, we think that we cannot talk ethics without the competency of M, the medical issues, you know, the diagnosis and treatment of disease, you know. If this is not up to date, you can be the most compassionate doctor on earth, but you get the diagnosis wrong. That's not ethical, all right? So I think that the first part is that competency, the core competency. But second, this is my favorite, empathy. I think if we have empathy, a lot of the world problem can be solved, all right? We can understand other people's perspective. And I think this is big. In fact, there is a society called the Empathy Society now being launched by various people. Gomez is one of them, saying that whatever your background, culture, and so on, if people are equipped with empathy, alone maybe, that should be enough, to ensure at least you don't go on and harm people and so on. Empathy is very powerful. Then respect, all right? Respect of one's different opinion, respect of someone's form of dressing, for example, gender, sexual orientation, just respect. You may not agree with them, but just by showing some respect for that, I think is very, very important for a doctor. Ability to communicate, and the C can also stand for compassionate, being compassionate, and ability to understand patients in terms of their insight. So in USM, we use this 8 memoir to tell our students, these are the 5 core values that we think you should have. And having this would at least ensure us teachers that you will go out as an ethical doctor, as ethical medical student. And we put it together as mercy, all right? And you are a merciful doctor, hopefully, all right? Okay, so imagine, we see a doctor with who have this value, who has these values, ability to have the accurate diagnosis and up-to-date treatment, understand our feelings, respect the differences. Although the patient and the doctor may have different sets of value, I think if a doctor or medical student has all these qualities, and I think there is less likelihood of you suing those doctors, even though he makes a mistake. All right. So I think we have been doing this now for almost more than 2 years, and some data is coming in now to say that this kind of 8 memoir for students actually help them to undergo an ethical assessment and ethical perspective. About people, medicine deals with people. Clearly, people are of different culture, going to understand that. Behavior, belief, and so forth. Language, and so on. Because sickness and health and reaction to sickness are closely linked to all these values. So we need to understand that. So it means that the theoretical part of ethics teaching must have sound background on theory of human behavior. There is no excuse on that, right? We must understand the theory of how people behave during health and sickness. We must understand what are the key features in effective communication. Knowledge of culture of the population. What are the likes and dislikes of certain population? That is a must-know for our medical students. Some legal issues. So all these things can be done in a theoretical manner, not by doctors necessarily. Of course, people use sociologists, psychologists, maybe the media and communication specialists, or the medical doctor, actors maybe, or anthropologists, lawyers. All these are interprofessional. They can provide us with a very strong fundamentals on all these issues, all right? That's the theoretical part of ethical teaching. But the ethical teaching that can mold behavior of students, that can form their attitude, are things that what Professor Mohd mentioned this morning, how they silently watch you, what you do and how you behave, either in public or in private. Okay, this is something that we don't quite. That's something which is proven to be the case. The conduct of the teachers, the role model has been said this morning. Perhaps the environment of an administrative system in place. When you are put in a situation that there's not enough of everything. It's really, really challenging to be ethical and doing things in an ethical manner. So all these things are behaviors and environment that will shape their thinking. And they will reflect on that and they will tell stories on that. What are the best setting of this? If we agree, and I hope that you agree with this, that this is a very powerful, the community is the best laboratory for teaching ethics, that's the best setting for ethics teaching, where do we go? So we go on experiential learning. We must put enough emphasis on experiential learning, which is learning through experience. Learning through getting the students right in the field when there is a major earthquake. The Ministry of Education now talks about flexible learning. The flexible learning should go one step further now, not just flexibility in terms of credit transfer and so on. But when you're doing pediatrics posting for 6 weeks, on week 4, major disasters happen in somewhere involving children, you stop the teaching and go with the teachers there. That's my proposal. Most deans will say, no, not possible. Exam coming up in 2 weeks' time. I said, let's do really flexible teaching, all right? Because that's the best setting now for anything pediatrics, whether it is pediatric medical, psychology, environment. That's the best setting for experiencing this. Because it's learning through reflection and doing. Like going to the zoo and learning about interacting with the zoo environment, as opposed to reading about animals from a book. This is, by definition, the experiential learning. I mentioned to you earlier, before I go on to show to you a real life environment of how things happen on the field. These are the empathy centers. Centers that actually light up when people are being put in an environment that requires empathy. They're put in an environment where they hear somebody screaming for help, really desperate scream. Then at the same time, they scan the brain. And they see that in the brain, there are certain specific areas that light up, That is the empathy center. We want that empathy center to keep lighting up by exposing them to situations where empathy is required, all right? And there's nothing short of that except exposing them to that environment. And because we know also that psychopaths do not have these centers lit up. They may have been brought in an environment where they maybe it was genetics, but maybe there wasn't enough to stimulate that situation where empathy becomes a rule. So we know clearly that by exposing our students, by exposing someone who's in training, by exposing our children to such environment, we know physical changes actually happen in the brain. Centers get lit up. And I think this is a very powerful thing to say that we really need to go on to that. This is very recent, this was 2 days ago, where in addition to empathy centers, we are now mapping altruistic behavior and how behaving in that environment causes certain areas of the brain to be light up. This is really an advancement because of the functional MRI that we are now have in place. Let me just sidetrack a bit, all right? I feel that medical schools are ailing. I feel that our lecturers and teachers and role models, we are overworked, outnumbered maybe, because we are put under extreme pressure to publish. And that may not be all that good for the profession, for the medical profession. Because from experience, I know that when there is, when the rewards are given to those with papers and publication of papers, and the reward and rewards are withdrawn from those without, that shapes behavior. And I know that people who want to stay in an institution where they want to continuously be rewarded will actually avoid the thing that they should really be doing, which is staying with the students, working with the students, and performing the role model, all right? And their approach to medical education becomes non-imaginative. The role modeling suffers, and that leads to a very tired and uninspired students. Okay? So when we hear now in Malaysia, there are issues about residents making gross, unimaginable errors. The soldiers in the army, we say that there are no bad soldiers. In the army, we say that if there are no bad soldiers. There are no bad soldiers. There are bad generals, but there are no bad soldiers. Okay? So I think this again emphasizes that we must not just bang our students, or scold them for being uninspired, but the inspiration actually comes from us. So we need to find a way, to find the right setting to bring back their altruism and the excitement of medicine. And there are many opportunities to do that. Take them away from the war and expose them to real environment. Not just in elective. Now we have elective posting where you can go or opt not to go. Make it a compulsory thing to do. Go out there in the community and talk to these kids. Bring them and talk and make them meet with kids with SMA, and many of them wondering about getting married. And these are real happenings. These SMA girls, they are 23, 24 years old, talking about reproduction, for example. The students have to be exposed to that. and be familiar with these issues, okay? Make them do sabbatical, which I've done. Sabbatical with the Bomo. I spent 3 months going around with a shaman, you know, picking herbs in the jungle and understanding how he communicates with the patients and how these Bomo gain confidence from patients. I know how they talk. They're not like us doctors who just, you know, give orders and expect obedience. No. You know, so make these students create environments for them to do that, and I think we in the position of leadership should be able to do that. Make them visit children in their homes, all right? Make them go on hospital, field hospitals. This was in it was in Yogyakarta. This was the earthquake in Yogyakarta. Unfortunately, at that time we had no students with us, because I don't want to fight with the school administrators, you know, want to bring students. But just seeing that mother who walked a long way to this field hospital and with a baby who's, by all intents and purposes, we couldn't cure him because this is a hypoxic birth and delivery that has produced that. But that you know, that hope on her face should be observed by students, you know. And should make them feel that, you know, when they're housemen, they have to rush when an fixated baby is born. They have to rush because they see that. They see a mother who's, with all the hope, walking all the way to see a doctor, hoping that this doctor from Malaysia can do something about it. They need to understand the dynamics, all right? And there are other situations, okay? This is in Taiwan, the palliative care group in Taiwan. This is it's best forgotten now. This is a big earthquake in Aceh, and there was some students who came with us, and we didn't realize when we came back from this experience, we were very grumpy. We just sort of, you know, and my psychiatrist says that is PTSD. That was PTSD, post-traumatic depression, because I thought I was strong enough to see that, deal with it, and come home. But when we went home, the images, you know, the memories linger on, and that shapes your thinking and so on. So for some time after that visit, the psychiatrist, yeah, that was PTSD. You know, I said, nah, it wasn't. It was, all right, okay. But that was like reading a big, major textbook on humanity, right? How to deal with other people, how to work in a group. And I wish more students could come, because that doctor is digging a well, together with a doctor digging a well, you know, making. He's an ENT specialist, right? We went there with the Mercy, with a group of the Mercy Malaysia group. The doctor felt that we were going there to give medication, you see. But no, you're not required to give medication. There's nobody with flu. People have no water, all right? So we had to dig wells, and in the process understand how that is done, and so on, all right? This would have been unthinkable, that scenario, you know. Malaysian doctors eating the same food as Chinese doctors. Malaysian Muslim doctor eating the same food from the same can with the Chinese group from mainland China. In Malaysia, we don't need to do that, all right? But when your thinking, your aim, your desire was on one aim, to get people better, and you tell the same stories, you sit on the same table with people, people who in another setting may be somebody who's your enemy, maybe, huh? But in a setting where you are required to do one thing, which is to help those people, to help these kids, you know, you forget differences. And I wish more students could come with me and watch that, right? And watch how in an environment of interprofessional relationship, you can work together with people, somebody who may not be luxury to work with you in another setting. So I think this is a very powerful messages, you know. And there were some students with us, you know, on that trip, and they were involved and so on. They should see that these kids were these orphans, you know, because on one of the islands, you know, the whole island was wiped out. They were lucky to be alive because they were in a boarding school. They were in a boarding school, but the parents stay in the island, so the island was wiped out. But being in a boarding school, they were safe, all right? And people send them clothes and so on, and they were making mockery of all this. They say that these are clothes which are meant to be discarded, all right? And you send them as though you are helping them, okay? And people send them bags and bags and shiploads of dried noodle, and they're sick of dried noodle. Students should see that. Students should see that and learn from that, all right? The other more recent disaster, unfortunately, was the flood, the big flood in Malaysia, 2014. And again, there were many students involved there. Many students involved there. I can bet you, students who you speak to now, 2016, and how they experience working with the flood victims 2014, they will have things to say, they will have narratives to say. And I bet you these students will have better perspective of people, and more than what the books can tell you, all right? They will tell you that, because all there was flood water, they had to break that pipe, and bring in rainwater. There were a group of students with us in the area, and at the time I was with the army at the time. We tell them to be entrepreneurial again, sell something and so on. Look at this guy, all right? He had a weighing scale with him. And if you want to jump on that weighing scale, pay him 10 cents. All right? So that's entrepreneur. Okay? So all these things are important things that you can, and you can learn a lot from these kids, one of them, this one, I said, what do you want? If you go back home and after this disaster, what would you want? And he wanted a blue tender, he wanted a blue tent. I don't know why he wanted a blue tent, but he said, even when you go back to Malaysia, please remember, bring me a blue tent. I couldn't meet his wishes, but I think it's very, very enlightening talking to these kids and working with people from other, these are from Canada and so on, and relying on these, folks, the pilots and so on. And so I think observing interprofessional relationship and how to work in that environment will have a very powerful effect on students' behavior. And of course, they will have the medical knowledge to go with them, but I think, to me, this is the setting that we'll have to expose them to. All right. This is a 2014 flood. You see, there's a medical student there. This is from the lab. He's from the lab. He's the chief of Mercy Malaysia. He looks like orang asli kan, this guy. Yeah. He didn't look like an orang asli after the haircut. That's my son. And then the other, this is from AIMS, from AIMS University. Right? We were there together from AIMS University, Sunatan, China, and so on. So exposing medical students, doctors to that, I think will reduce this. Will reduce that perception of medical dominance, and that will hopefully bring down the self-aggrandizing hyperbole that we have with some people, who thinks that they can cure, bring life and death and so on. It will reduce that. It will make the medical dominance less prominent in a multidisciplinary teamwork. It will make them more humble, hopefully, reduce their arrogance, and that's what we want in the medical sector. We want people with humility, people who can accept differences and so on. And I think this is not just the case of medics, it can be applicable to other forms of professions as well. So I think we need to have the theory, of course. We need to have the theory of human, like I said earlier, legal issues, that has to be theoretical. But the experiential learning at first opportunity must be there at first opportunity and not just an elective or go if you can, like nothing. We must make enough room in our curriculum to allow for that, right? Allow for that kind of flexibility. Maybe we should bring students from various disciplines, we should bring students from medical, nursing, engineering, food science, dietitian, philosophy, although they come with different entry requirement, but in certain settings they are together in the same group, PDL, for example, and discussing things of the same interest. Flexible learning, and maybe capping all that, we'll probably have an annual students conference, to relate these experiences with particular issues on ethical emphasis. And I think I'm not sure, I mean, people have done this already, some groups have gone out to do things, but I think we should try to make this as formal as possible, because there's no other way in my mind to produce an ethical doctor except by having them go through a real experiential learning, like what I've said earlier. So as conclusion then, ladies and gentlemen, it is a very simple message that in the professional education, it's not just professions as we are, but go from deep to students level so that we can produce a collaborative, ready workforce. We need to ensure, if you are deans, you are heads of department, if you are VC, make sure you create a flexible learning environment, because higher education is a nurturing of character. It's a nurturing of character and attitude formation, in addition to wanting the students to become content expert. Higher education is the best platform to provide that kind of nurturing of character and attitude, and I think that that can be done from the way that I've said earlier. Thank you very much for watching.
Thank you, Prof. Zabidi, for challenging us with this new idea, as always. I think we still have quite some time until the next session. Taking questions here.
Prof. Zabidi, thank you very much for the very enlightening lecture. Okay, you suggested that we bring our students out. Of course, some of us are also doing that. But over in my place, we have started doing, for the final year, for the ethics exams, we do not have, we have got one exam paper we sit down, but there is one whereby the students have to actually present cases that they have got when they go around in the field. I give them a period from the time that they come to the medical school from year 3, and at the end of the year 5, they are supposed to present a case that they have got from anywhere that they have been. So, and most of them actually got the cases from the wards. So the last professional exam when we had our ethics component, 35 people presented cases. And out of the 35 cases that they presented, half of it was showing doctors doing the wrong things. So it was, so it was actually a big issue that came out of it. And we have actually learned a lot from the students, and the students are actually very good at picking up. So it's not necessary just to go for during disasters. Like in my university, it's very common for us to go anyway, because for Kalkara we went actually for the whole medical faculty, because we're in the defense university, so the battalion was actually under us. So we just went with them. But the thing was that we also found that by doing this stuff, where they go around in the ward and find for themselves, observe and get the cases, lo and behold, we're seeing that we ourselves are role modeling the wrong things, So they're saying, but then now he go and shouted at the patient. I said, okay. Oh, then he brought the children inside the treatment room. Their children, because they were called during at night, so they brought the children into the treatment room. So we had all those funny things happening. And in the end, we added in one more thing, say that next time when you see that happen, can you try and respond by actually telling somebody about it, or talk to that person about it, because we need to intervene, when something like that happens. Some of them are really crazy and very dangerous things that the senior doctors are doing. Okay? Mark my words, it's the senior doctors are doing. It's not the junior or anything like that. It's the seniors one. So I think I actually when I invented the ethics from my city, I found that when I did it this way, the students were actually telling me, oh, we have to be very careful. We actually really have to think and not just follow the seniors. Yeah. So this is good. Thank you very much.
That's a good comment.
Thank you.
Reflective diaries.
Yeah. Should be one, the Ryan, and then you, the Zoe also, another one, and the Azhar. Right. I will start from Ryan.
Changing the behavior of the individual in terms of virtue is something that is doable on the level of the individual. My concern is, what about these democratic deficits, for instance, systems that somehow undermine the decision of the individual because his superiors wouldn't allow it, the inability of the person to make his own judgments, insofar as there are injustices in the structures, in the hierarchy. We can talk, for instance, of bureaucratic systems and the inability of people to make the right judgments because they are under the domain of those people who have control over them. So what do you think most importantly should be done so that we can professionalize for the bureaucracy and all of these things in order for people, especially the rural areas, to have access to good and quality healthcare.
I think that involves a key strategy of how to influence change, and this is a big subject. How you see something wrong, how do you make a change? And there are various steps, how to make a change. We don't have time to go through all of that. But I think we should give that particular skills to our students, because a student who see that there's something wrong, if he just blurt it out and say, hey, why did you do the wrong thing? Surely that's not the right kind of skills he should have, So I think one of the elements of the fundamentals, will probably be how to influence change, how to make sure that people actually do change with time and with patience and diplomacy. So I think this is a separate issue, which I think it should be one of the essentials, essential skills. In addition to how to communicate, influencing change will be another. I agree with you. That's a separate skill, very, very important skill.
One comment, question, comment for many people. I mean, how far you want to expose students to community or event. I think that's probably. I'm not sure which one is enough, but that depends the occurrence in the community, how they observe into the community rather than the event itself. How big the event? You mentioned about go somewhere and then see. I don't think it's really necessary. If they go without learning, without doing things that's necessary, that's also useless. So I'm thinking that's what we did, probably enough, but probably we need to see if we can improve further in terms of
guidance.
Just more. Yeah. But the main question I want to ask, the attitude and empathy, that I'm not sure whether is it important factor from the experience. We thought attitude is a main problem that we cannot change students. So that I'm asking you.
Can we change attitude? Is it possible to change attitude?
Can we teach ethic, and then the student will follow that properly, even though their background, attitude, their concern is a difference. Some students not come from, medical students not came to the university to be a doctor, sometimes for something else, but it's forcing by the parents to be a doctor. So it's not easy to teach ethics, and then you can teach in theory and then pass the exam.
Yes.
But when they are houseman or work after, they are different doctors.
True. I'll give you an example of a twin medical student, from Penang. These twins, have never been in rural environment. They've never seen misery. They've never seen poverty. And in our program, we make them stay in the CFCS program. We make them stay in the community, not just go for the day and come back in the evening. No, they actually stay in those houses, And the twins came to see me after that and said, "This is the biggest thing that changed her attitude." She says, because she sees how difficulties people have in the community and so on. So I think it is possible. It is possible to expose people to real life experiences, and change over a period of time. May not be one event that change people, but a series of exposures, like us, after we go through a series of exposure to certain things, our attitude will probably change. So I think let's not despair. Some people may come from a very posh environment. I heard my son telling me that Form 5 was one boy in Form 5 in one of the schools driving BMW now, and looking very, very royal in terms of look and so on. But I'm sure such students should be exposed to another environment. And it's the exposure of environments that will change people. I think I will not despair. I think we should provide any opportunities. You don't have to wait for disasters to happen, but have enough opportunities in the curriculum to make sure that that's done. Right? And I think that is something that needs strategy. And when they go out there, they don't just go out and do wild things. They go out with a certain thing in mind. Another example that I can give you. There is often a hidden kind of competition between certain religious groups, right? Somebody from one group say that I do these things better and so on. And I can tell you a real example, of how someone from one religious group went to Malacry during the disaster. and went back and told me that we were so impressed with what the Suchi, is that how you pronounce it? Yes, the Suchi group and how they behave, and we were so impressed. And even though this group was all the while saying that we are the best, we give all this and that, but when they saw the Buddhist group working, they said we're humbled by that. You know, so I think that is a crossing the border of religious arrogance, if you like. You know, when they saw somebody doing better things, and they may not be of the same faith, you know, but they appreciate that this is much better, much more systematic, and that was a real happening in Kuala Krai. You know, so I think there's a lot of opportunities to make people learn. All right. Through this kind of opportunities. Yeah.
Dr. Asif?
Yes, thank you for sharing your personal journey in bioethics. So you highlighted a lot of pros of experiential learning and the cons of theoretical learning. So, and this is related to what was discussed earlier. So I'm not from the medical, I'm not a medical doctor, so I may be ignorant. How difficult or what is being done to incorporate experiential learning as a core or compulsory component of so-called the curriculum to train the doctors and how the bioethics training? What is being done, what's the status, and then how can we measure? Because I think you mentioned about it's easy to measure, so we do that. Can we somehow measure these things too, so that it can be also incorporated?
In Malaysia, the system which is good at measuring is the Medical Association, MMC. You know, they have certain prescribed weeks of clinical exposure, and that's experiential. You know, the students will have to spend 120 weeks seeing patients. You know, and by that they mean 120 weeks seeing patients in the ward. All right, that's standard that nobody can argue with them. You know, but what I'm saying is that if we are curriculum planners, if we are people who are concerned about ethics, my view is that that standard prescribed exposure need to be supplemented with something else. You know, need to be supplemented with something else which is bigger and more transformative in nature. That's what I'm saying. You know, so as it is now, maybe cut the curriculum. People in McMaster's, for example, they do a 4-year program. In the first year, they send the students in the ward already. They're already there in the ward and doing things, being guided, of course, by the seniors. You know, so I think we should really trim the fat from our curriculum. There's so much fat in our curriculum, right? So much unnecessary issues in our curriculum. Geneticists want more and more genetics. Sorry, you're a geneticist, not that. You know, the neurologists want more and more neurology. And so on and so forth. I think we should be able to be wise enough to say that let's trim the fat, you know, and make sure that we are producing a doctor with character, and by making sure that there is enough opportunity in the curriculum for experiential learning, not just in a ward setting, which may be artificial. It is artificial. A hospital is better than a hospital, all right? Where people in a house and how they relate their sickness in their own environment. That's a better reflection of what they are. We know that kids, when they come to hospital, the developmental achievement goes down because of the hospital environment. All right. So we know that hospital environment is not the best environment for providing such an opportunity. So it means that they have to go out more than being in the hospital. Going out more where? That's the challenge for the curriculum planners.
Is it Prof. Siti?
Yes, Prof. Zabidi. And my concern is about how much bioethics content there is in the medical curriculum. Alright, so but you just said the magic word. Okay, trim the factual aspects of the course, right, medical course. Because I mean, I think 10 years ago I was at this conference whereby we were trying to, in fact the minister at that time actually was speaking about putting in medical ethics, courses within the medical curriculum. But he also spoke about the difficulties because you have so much, modules, so much credits, to cover in say 5 years, and then right after that they go for housemanship, and then they do that for say only for 6 months, get internship in hospitals. It's just about attending. It's about knowledge. It's also knowledge based how you attend to diseases. So you do not actually treat the patient, you just try to treat the disease, and people say that in philosophy. So in the end, where do we go from here? how fast you think we can sort of change the medical curriculum? You did say that, I mean, hospital is not the best place to work. You know, after some time you tend to follow the behavior of the nurses. You know, nurses are sometimes very fierce to patients. And same thing with doctors. When very young doctors quickly emulates the nurses the way they behave. So, I mean, similarly in any education, you know, you have to go to the communities where you learn about social engagement. You know, and that's the only way. And experiential learning should move beyond hospitals. Maybe I just want to know how soon do you think?
I think, yeah, I think we should be able to achieve it. I mean, we used to be criticizers before, you know, we criticize whatever you're doing curriculum, there's something wrong. Before we know, it's 25 years, and we are in a position of leadership, you know, and many of you are in that position. You used to be teachers before, teaching, but now before you know, you are actually leaders of your modules and so on. So let's not wait for somebody else to do it, you know, wherever you are, at whatever capacity, you have to take that leadership and make sure it happens, you know. So I think this will be the way forward. I'm sure all of us here have leadership opportunities, big or small, you know. But I think whenever you have that leadership opportunity, that's the time you make changes, you know. And ask, if you're not in the leadership capacity even, you know, you may ask for changes to be made, okay. And I think it takes time for things to happen, but Rome wasn't built in a year.
Can I ask one more question?
Sorry, I've seen Prof. Taylor.
Yeah, no,
Then Dr. Nawawi.
I think I liked your suggestion to take students to the times of disaster. Well, you can include it in the curriculum in some way. You can ask them to develop an action plan of what they would do in a disaster. And some types of disaster are routine. For example, typhoons, landslides. These happen every year. Even within a country, like Indonesia, you'd have an earthquake every year. So the place may not be predictable, but flooding and typhoon damage are fairly predictable. So through that, and we've done some things of that with these youth looking beyond disaster plans. Also warfare. Conflict zones. The problem here is that administration may not want to take the students to a conflict zone. But of course, if your country is in conflict zone, such as you're a student in Iraq, or you're a student in Syria, you have a conflict right now. So as sad as it may be, and as risky as it may be, now then also, let's say you live in a conflict zone, can we change the credit system to give more credit to community service work, to replace credits that would have normally taken in the theoretical background? And I think sometimes some universities are doing this as well.
That's correct. In fact, we don't have to wait for such disasters even. You know, there are enough nutritional disasters happening in certain places now. In Sabah and Sarawak, in Kuala Krai, Buang. You go in that community, you will see disasters. As disastrous as typhoon maybe, but these are nutritional disasters, people with nutritional deficiencies, you know. So, but it needs, you know, there's a reluctance now in medical schools going out, all right? Because, going out, it's time, it's money, expenses, we need to publish. I hate that, all right? Okay, I'm publishing, okay, but I really feel that it's going crazy, you know, that kind of obsession now, okay? But we have to publish, okay? But make it reasonable, you know, and make the right expectation, okay? I think Zawi.
Just want you to comment this from my observation. We see the doctors right now, their attitude, empathy is less and less and less. But in terms of knowledge, way you teach is getting better and better and better. So why this one is not made? I mean, we should improve the teaching method, teaching technique, plus we include this one, should be produce better doctor.
That's right.
But it's not. So something wrong in between.
Not yet, not yet.
But how long we want to wait? I mean, I'm not sure. That's why I'm asking you. Because I see a different side of I see a product other than a factory.
1999, prior to 1999, nobody talks about ethics module in USM.
But we saw the better doctor last time.
Okay, so also better doctors, okay. So yeah, the better doctors may have gone through a different system of role modeling, different environment, and so on. You know, it took a long time. Before even a small module on ethics, talking about ethics. Because every clinician say, okay, we'll teach them ethically anyway. That's the kind of dismissive attitude to say that, oh, we don't need an extra ethics now. There's enough that we do to make the students feel that it's already ethical. That kind of attitude. That attitude is still prevalent now. It's still prevalent. If you, in most studies, when you talk about asking clinicians to teach ethics, there's a natural reluctance. It's already ethical, that kind of thing. That's sort of defense mechanism.
We still have about 5 minutes to the next session. If any of you have burning questions or comments to give. Alright. Okay. Thank you very much, Prof. Zabidi.